Good morning and welcome to the Department of Laboratory Medicine Pathology Grand Rounds. So today we have an awesome presenter for you. So Dr. Padmanabhan is a consultant and associate professor in the divisions of hematopathology, transfusion medicine, and experimental pathology here at Mayo Clinic in Rochester, Minnesota. He received his medical degree from Thanjavur Medical College, his Master of Arts and Ph.D. from Brown University, and underwent residency and fellowship training at Columbia University and the University of Pittsburgh, respectively. Dr. Padmanabhan directs an NIH-funded laboratory in the area of platelet immunology focused on understanding the pathophysiology of heparin-induced thrombocytopenia, HIT. His research emphasizes translation of research findings to improve diagnosis and treatment of this condition. Let's give him a warm welcome. Thank you very much.
Thank you very much, Dr. Kreuter, and thank you for the department for asking me to speak today. I was told the audience is going to be diverse from various areas within DLMP, various different laboratories. So what I've strived to do in this presentation is to provide sort of a general overview of the science in the field and focused on its impact on diagnosis, because, you know, in DLMP, a lot of what we do is related to understanding pathophysiology if you're under the research arm, or you know, making diagnoses for various diseases if you're in one of the clinical laboratories, or teaching trainees that pass through. This slide summarizes the learning objectives of this talk. The first is to recognize that platelet factor 4 is a target of antibodies in certain prothrombotic states. Specifically, I'll be talking about HIT, VITT, and a new entity called MGTs, which I'll describe. And acknowledge the heterogeneity of presentations in anti-PF4 mediated syndromes. Some will have thrombosis, some will have thrombocytopenia, some will have both. And discuss the pathophysiology of a recently recognized anti-PF4 mediated prothrombotic disease, again called MGTs, stands for monoclonal gammopathy of thrombotic significance. So I always like to sort of tell this like a story. And, you know, I've been doing this research in this field for, you know, more than 15 years, and it's really hard to compress all that in a 15-minute talk. But what I thought I'll tell you is, you know, where I started, what it led me to, sometimes unexpectedly, and then where we went from there. So again, this would be sort of some of the high points of the research in this area. So I got interested in HIT, heparin-induced thrombocytopenia, which is a severe adverse effect of heparin treatment, which I'll talk about in a bit. Heparin, as you know, is one of the most commonly used drugs, and certainly the most commonly used anticoagulant in use in our patients. And as a transfusion medicine physician, every year I would see maybe 1 to 2 patients. It's not very frequent, but really what we think is sort of catastrophic HIT. So thrombotic disease that is refractory to current standard therapies, for which we're doing plasma exchange in order to remove the antibodies that these patients have made. And so it got me thinking about the pathophysiology of the disease, and also, as I'll describe, got me thinking about some of the treatments that we have and how perhaps we can develop newer treatments in the future. And so the first question I asked when I saw these patients was, why do patients thrombose even after heparin is stopped, right? Because a lot of these patients that come up with, for example, apheresis, heparin has been stopped a week or 2 prior, and their thrombosis, unfortunately, is progressing. And heparin is thought to have a central role, not only in the initiation of the disease, but also the propagation of the disease. So if the latter is true, why are these patients continuing to do poorly? And so that's when I sort of went and you know, asked this question and went to the research lab. And we came up with what we believe is a fairly good explanation of what we think was going on. And as a laboratorian, we asked the question, can we leverage this new knowledge to develop a new test, a new diagnostic test? And we came up with an assay called a PEA, which stands for PF4-dependent P-selectin expression assay, and I'll describe this story a little bit. And also we noticed that some of these patients are doing very poorly, but HIT is a rare disease. So in any given year in the United States, roughly there are about 20,000 patients. So you take any one physician, like say one hematologist, he or she may not be seeing a lot of HIT patients, and their views on outcome may be influenced by the few 1 or 2 patients they see over the year. I had hematologists say, oh, the outcomes actually are very good. Patients get diagnosed, they get treated, and they go home, no problems. And some of the view that this is a terrible disease causing amputations and death. So we wanted to ask the question, what are the outcomes? And this was sort of a new field for me. I've never done anything related to sort of looking at outcomes and epidemiology and disease incidence and burden. So that required me to do some learning and most importantly, collaborating, as I'm sure you all do with different areas where you may not have the expertise. So this ended up being a much, much larger project than envisioned, but I'll show you some results of that. And the bottom line is HIT is still a bad disease. We think the mortality rate is 10%, which is in line with some smaller reports that are out there. And then we asked the question, this for a non-malignant disease, this appears to be fairly morbid. Are there better ways? Are there other ways to be able to inhibit the antibody that causes disease? So how do you inhibit HIT antibody-mediated platelet activation? And I went back to the lab and we and others have found that in really severely afflicted patients, intravenous immunoglobulin G might offer some benefit. And more recently, there have been 2 new diseases. So HIT was the only disease pretty much in the platelet immunology space, well, other than ITP and so on, and PTP. But there's 2 new diseases. They came up. One was unexpected. So you've probably read about this in the newspapers. Thrombosis after certain adenoviral vector vaccines, like the Johnson & Johnson, AstraZeneca COVID vaccines. And it was given a new term. It's called VITT. And we got thrust into this space because there's not a lot of labs studying anti-PF4 antibodies. And so I think this was in April, and 1 week we had to do interviews with NPR, USA Today, and another, was it NBC News? So, people, the thing is, it was like, what's happening here? How do we understand this? That was all a good thing because now physicians from around the country knew that we existed as a lab. And so they started sending patient samples to us. And we're following, I would say 10 to 12 VITT patients currently in the US. And most recently is a paper published last month in Blood, where we describe a new syndrome. There's certainly case reports of this type of presentation, but people haven't recognized what this was. Based on testing, I'll show you, we believe we have a new syndrome that causes recurrent thrombosis and periodic thrombocytopenia, which we're calling MGTs, or monoclonal gammopathy of thrombotic significance. So sort of the family of diseases in this space is, expanded quite suddenly over the last couple of years. So this is sort of the overall flow of the talk. I'll talk a little bit about background pathophysiology. I'll spend a decent bit of time on diagnostic implications because I know you all are interested in diagnosis. Very briefly talk about the disease burden to show you some of the data on, how many people thrombose and bleed. We don't think of bleeding in the context of HIT, but it's important, as I will describe. And then go into novel therapies and the VITT and MGTs discussion. So what is HIT? It's, like I mentioned, an adverse effect to heparin. It occurs in less than 1% of patients treated with heparin. There's, various estimates you'll see from, up to 5%, but really we don't see that anymore. Possibly it was relevant in the era where, maybe orthopedic surgery where everyone was getting unfractionated heparin. But really, even in the high risk setting, when I mean high risk, I mean cardiac surgery, that's probably the highest risk setting for HIT. The risk is about 0.7% based on some work that we have done. Now, HIT is characterized by low platelet counts and a relatively high thrombosis rate of about 30%, as I will show you. In terms of terminology, in years past, people, and even sometimes now, you hear this HIT type 1. It's a non-immune thrombocytopenia, and usually, we discourage folks from using this term because it can get confusing. You say, patient has HIT, and then you miss the type 1. You think patient is immunologically driven HIT. Type 1 HIT essentially is when you give heparin to an individual, for the first time, you have a slight drop in the platelet count. It's very transient, it recovers. There's no sequelae treatment. The more serious part is obviously HIT type 2, which we call HIT now. It has an immune basis, and some people use a second T, HIT-T, to describe HIT with thrombosis, because you can have HIT with just isolated thrombocytopenia. Now, what is thought to be the underlying pathophysiology of the disease? So it's thought that when patients given heparin, which is denoted by this black squiggly line, which is highly, highly negatively charged, it can bind to PF4 depicted by these 4 circles. It exists as primarily as a tetramer at the pH of blood. So you have a PF4 is positive, heparin is negative. They form a complex, and PF4 exposes neoepitopes that are recognized by antibodies that some patients make. So this Y is an IgG antibody. It binds to the epitope, and then with the Fc portion of the antibody, which is the bottom part of this Y, it can then engage an IgG receptor on platelets called Fc gamma R2A. This is an activating receptor. So when this engagement occurs and clustering of receptors occurs on the surface, you have activation. So this was believed to be the primary driver of platelet activation, thrombocytopenia, and thrombosis. Now, it certainly may be in play, but we felt that it does not fully explain what's happening in HIT. For example, I described to you, patients sometimes have first thrombosis occur a week, 2, or a month after heparin is stopped. They make the diagnosis, they stop the heparin, patient goes home, comes back with a thrombus. So if heparin is so critical, as I showed in the prior picture, why is it that patients are prothrombotic? Why is it that we have to anticoagulate them for 3 to 6 months after diagnosis, right? So we felt that heparin is not necessarily required for propagation of the disease. Clearly, heparin is important for disease initiation in 99.9% of cases. And I say 99.9 because there's an entity called spontaneous HIT, which I'm not going to talk about, where patient hasn't received heparin, has been sitting at home or doing whatever, has not been in a hospital, and comes in with severely low platelets, blood clots, and you do the blood testing, it looks exactly like HIT, okay? But it's spontaneous. So it's sort of a misnomer. It's a spontaneous heparin-induced thrombocytopenia, but I guess and the term has unfortunately stuck, which can be confusing. But anyway, so the prothrombotic state that exists after heparin is ceased, treatment is ceased, doesn't fit the model. And again, some severe HIT states like spontaneous HIT and another entity called delayed onset HIT can occur in the absence of immediate, in the case of spontaneous HIT, can occur with no heparin exposure. In delayed onset HIT, the heparin given is a week or 2 prior. Heparin is a short half-life and it's eliminated in half a day. So really when the disease is occurring, the thrombosis is occurring, there is no heparin in the system. So an alternative model that we proposed was PF4, this is the molecule, the 4 tetramers, that it binds to negatively charged material on the platelet surface. In this figure, we propose it's a platelet glycosaminoglycan. Heparin is a GAG, and there are other GAGs in and on human cells, including platelets. And so we're proposing it's a platelet GAG. So if this occurred, you have PF4 binding to something negatively charged, exposing the epitope. In fact, this is even better. The target is tethered onto the platelet surface as opposed to being in the liquid phase, as I showed in the previous figure. Fc activates platelets through Fc gamma R2A. And so this just summarizes what I just told you. And the key takeaway here is, if that is true, if our hypothesis is true, you do not need heparin to mediate HIT antibody binding to and activation of platelets, right? If all you need is a PF4 binding something on the platelet surface. And this is sort of some early data from many years ago that we showed. What I'll really have you focus on are, these are sort of pathogenic antibodies. These antibodies are from HIT patients. And if you just focus on the right of this figure, these were added, these sera were added to platelets that were either treated, which is this part. So the platelets are treated with PF4. Or here, if you look at the same samples, the black dots, the platelets are not treated with PF4. So when you treat platelets with PF4, you see that binding of IgG, so you're looking at the y-axis and IgG binding. When you treat platelets with PF4, binding of the antibody significantly increases. The open circles are non-pathogenic antibodies that bind in an assay called, PF4 polyanion ELISA, which I'll describe But the key differentiation I want to make here is the black dots on the right and the black dots here. So PF4, so here antibodies demonstrate PF4 dependent binding to platelets. There's absolutely no heparin in this system to facilitate the binding. And so surprisingly, you know, we've known about HIT for 50 years, and this was the first demonstration that you actually don't need heparin, which surprises me a little bit. But it just tells you the importance of sort of technical rigor. We had to do some of these studies very, very carefully. And so, and again, as a DLMP talk, I know you're all very interested in diagnosis. So we asked a question, can we leverage what I just showed you, the knowledge that we gain, into a new diagnostic assay? So before I go into a new assay, I'll want to talk a little bit about what are the current assays for HIT. Broadly, they're under two buckets. The first is an immunoassay, where you have heparin and PF4 on a plate, or you can have other materials that are like heparin, highly negatively charged. We use in our coag lab, we use something called polyvinyl sulfonate, okay, which actually happens to be invented by my mentor in Milwaukee, Dr. Richard Astor. He was actually also an entrepreneur. He founded a company, and this product is now being sold by Immucor. But we either have heparin or PF4 on a plate. And if the patient has antibodies, it's going to bind this target because, you know, HIT neoepitopes will be exposed to PF4. It's thought to be highly sensitive, greater than 99%, but it is non-specific, so 30 to 50%. In other words, if you get 10 positive results, only 3 to 5 of those 10 positive results are from patients who have platelet activating antibodies. So in the field today, there's an epidemic of overtreatment, right? So you get a positive, you get 10 positives, and this is a bad disease, so physicians will be treating all 10 of them. And typically they wait for a confirmatory assay, which is the bottom here. It's called a serotonin release assay. You add your patient sample to normal donor platelets that are treated with heparin. That's really important. They're treated with heparin. And if the patient is activating HIT antibodies, the platelets will get activated and will release radiolabeled serotonin that the platelets have been previously incubated with, or like we do in our lab here, Dr. Pruthi and Dr. Heikel have a test in the coag lab where we're looking at mass spectrometry. Okay, so this is considered accurate, but it is technically complex. And so we said, can we use some of the new knowledge we gained to, you know, to develop a gold standard assay like the SRA, but it's easier to perform. So this is the basic, you know, premise of the assay, that PF4 bounded platelets is the target recognized by activating or pathogenic HIT antibodies. So you take normal donor platelets, so these are healthy donors. You treat those platelets with PF4, platelet factor 4, which I should mention is a component of the platelet alpha granules. There's always a little bit of degranulation going on. There's always a little bit of PF4 on the surface of the platelet. So we add some PF4. Importantly, we do not add heparin. So the SRA uses heparin. You add the patient's serum, and you look at platelet activation. Now, we looked at P-selectin expression. We had easy access to a flow cytometer, but you can look at other readouts, and we have done that, including in an ELISA format recently. Again, very different from the SRA, where you use heparin, but not PF4. And so this describes sort of a very, I mean, this study took like 2 or 3 years, and I'm just summarizing this really quickly. But at this point, I was not here at Mayo Clinic, but I had excellent collaborators here at Mayo Clinic, Dr. Varad, Dr. Pruthi, Dr. Chen, and others. And what we did was we, through here at Mayo Clinic, Rochester, and the University of Washington, Seattle, David Garcia, they enrolled consecutive patients suspected of HIT. And what does that mean? So essentially anyone who got an ELISA done, okay? So the ELISA was done, well, they enrolled all of them. And we wanted to really see patients with acute HIT. So someone might have had HIT sent home, they're monitoring them outpatient to see the antibodies gone away. So we, you know, excluded them. And we, you know, and each of the sites, each of the 2 sites did something called a 4T scoring, which I won't go through right now because of time, but essentially it's a pretest probability scoring to say, okay, is your patient is likely to have HIT or less likely or has a low probability, okay? And I was blinded, so I was in Milwaukee then, so my team is completely blinded to all of the 4T scores, so that's how we conducted the study. And the samples were shipped to us, and they said, okay, do the SRA and the PEA. Okay, so we did radiolabeled SRA and this new assay called the PEA on all of the samples. And once the testing was done, we unblinded, and then we brought in statisticians to help us analyze and put together the results. And again, I'll refer you to the paper if you want to read more, or there's also a podcast and as well as a editorial commentary in the journal from 2021. But it performed quite well. You know, despite the fact that we had 400 plus patients, sadly enough, you know, only 1 in roughly 10 patients or so are confirmed, still suspected or confirmed hits. So we had a pretty small disease positive group using predefined criteria that include 4 T-scores and other things. But you'll see here the area under the curve in this test called a receiver operating curve test, which many of you may be familiar with as you use this for new test validation, was really quite high. Numerically, this appears higher, but I can't really say that the PEA is any better than the SRA because you see highly overlapping confidence intervals. You can probably say that they're no different. So which is sort of a good thing because this is really a non-radioactive assay, no mass spec. And again, we have recently used a different readout, thrombospondin 1, in an ELISA format, so much easier to read using the same technology. So, you know, there's other things that we're interested in, one of which was what is the disease burden of HIT? And like many things, this is something that, you know, when I waded into accidentally, I had a fellow come to my office and say, he's looking for a fellow project. And he was a clinically oriented fellow. And I said, hey, why don't you look at the disease burden as a disease burden of HIT? And this is how it started. And it ended up being a 2-year project. And I was very pleased that he got a paper in Lancet Hematology, which he was very, very happy about, helped them get a job and academic promotion, et cetera. So one of the things that highlights is there's been this, I would say maybe a myth that HIT incidence is really gone down. It doesn't reflect in the testing we do. And the reason for that is there's increased use of low molecular weight heparin, which is thought to be less of a risk for HIT. But again, we looked at a 5-year period in a large discharge database. It's the largest publicly available discharge database called the NIS, Nationwide Inpatient Sample. And we're looking at, I don't know how many million, I'll be misquoting, but I mean more than 100 million discharges, a very large number of discharges, and looking at several thousand sort of HIT patients. And what we arrived at is, and again, this is not perfect. There's problems with administrative codes that are given for diagnoses. So there are all of those caveats, but using the data that's there, and we did some sensitivity specificity analysis for the codes, which I won't go into, we found that it's reasonable. There is not much of a change over this 5-year period that we looked at. Back in 2017 or so, when we did the study, this was the latest year of data that was available. We haven't gone back and looked, but so we think the disease burden is low but stable. This is a rare disease. Given if it's anything less than 200,000, it's an orphan disease, which this is what it is. This is a kind of a crowded figure, but the 2 key highlights I'll make are. The first is on top, about 30% of people have thrombotic disease. Okay, that's pretty high. And the bottom is that the surprising thing is 6% of people bleed, 6% of these patients bleed. HIT is not a bleeding disease, it's a prothrombotic disease. And most people, including me, we think this bleeding occurs as a result of therapy. Okay, so typically you would give direct thrombin inhibitors, argatroban, bivalirudin, and there's no antidotes for those 2 drugs. And some patients bleed, and we have certainly seen patients bleed, especially more severe the disease. Sometimes your platelet counts less than 20,000 with HIT. Maybe 1 in every 20 HIT patients we see, you put them on argatroban, they're on a very, very high bleeding risk. So prothrombotic, the mechanism in HIT does not appear to protect against bleeding. So this is something very important that I'll mention later on. So some of the morbidity is because of the clotting that occurs, but some of it is also the bleeding that occurs. And so one of the things, we started thinking of was, is there a way? So right now, you have the platelet activation, which is the instigator in HIT. And then you have activation of coagulation because, you have phosphatidylserine exposure, the surfaces where the coagulation cascade can propagate. And the current therapies treat this step, the really only on label are DTIs, fondaparinux and DOACs are off label. And then, of course, the outcome is thrombosis, which you want to prevent. So the question we asked was, is there a way to affect or interfere with the first step, which is actually platelet activation. And this is in line with ASH guidelines, which is listed here, but essentially it says we need novel therapeutics that target pathways in the pathogenesis of HIT proximal to coagulation. What they're saying is the left part of the figure is what you need to attack, right? Because you attack the middle part of this figure, you're also going to make the patient predisposed to bleeding, right? So effective in reducing thrombosis without increasing the risk of hemorrhage. So it's very, very important that your treatment ideally doesn't cause problems, other problems that that are created, even though you fix the thrombotic process. Very briefly, I just want to show this cartoon because I felt that there was therapeutic rationale in the use of IVIG in this disease. So I'm not a good artist, and clearly I don't have my colors right. The blue should actually be red. Red is typically danger, right? But in this figure, let's pretend the blue is pathogenic antibodies. Okay, the blue are the HIT antibodies, and the red and green are antibodies that you would find in an IVIG bag, intravenous immunoglobulin bag, right? This is G1, red is G1, green is G2. So in this proposal, when you give somebody IVIG, giving a lot, like gram per kilo, 2 grams per kilo, the G1 and G2 normal immunoglobulins will go and occupy this receptor, the Fc gamma R2A receptor, and compete with binding of HIT. So in this cartoon, you see that 3 of the 3 receptors, 2 are bound by IVIG molecules, only one is, so it can't cross-link, and you have no activation. So there's clearly therapeutic rationale for use of IVIG, and there's rare use of IVIG in the literature prior to this point. This was an editorial I wrote in response to something completely unrelated to therapy for HIT, but it suggested this concept. And this is a patient that was very refractory. So a patient had cardiac surgery, went home in perfect condition. There's a patient on the West Coast, came back a week later with severe thrombocytopenia. So you can see here it was like, 11,000 is one of the lowest I've seen, and heavy thrombotic burden. And you see here, these little spikes here are really not the patient making platelets, but the patient was transfused platelets because the physician was exceptionally concerned but bleeding when you're giving argatroban, which is the ARG here, with such profound thrombocytopenia. So this continued for 3 weeks. You can tell their platelets aren't budging. I'll tell you the antibodies are fairly strong. And again, as a last resort, IVIG was given at 2 grams per kilo, and you can see the rapid rise and the sustained rise. So you see the platelet counts didn't come back down. So the patient was discharged 3 days after the drug, while the patient was in 3 weeks prior. Again, there's a case report, has to be taken with a grain of salt. But we had other reports in the same paper that we presented a similar kind of concept, and we showed from a mechanistic standpoint that the part of IVIG that's mediating this effect is the FC portion. Because here, for example, you have so the black bar is if you added IVIG in a test tube, you added HIT antibodies and platelets, so 100% is the activation. If you didn't add anything, you add the IVIG, you see pretty profound decrease in activation, which is what we would predict based on the mechanism. And you add FC, if anything is even better. Maybe FC is a smaller molecule, it can kind of swim between, there's less steric hindrance. It's very effective. So the open bars are FCs. And you can see these dotted bars are FABs. So FABs really aren't doing anything. It's the FC portion of IVIG, which we believe is very important in mediating the effect. There may be other things that FC is doing in a human being. We're not looking at impact on immune cells and antibody recycling, et cetera, but we think this is a key mechanism by which IVIG works. And, it was covered quite widely. And, for a period of time, I was actually documenting every single report of IVIG use in HIT for maybe a year or 2 after this. And, there's a huge spike in use. And of course, there's some publication bias and so on with that. But we now use this off-label routinely in the context of refractory HIT. In fact, in the Mayo system, we treated one patient here a couple of months ago who had HIT after stem cell collection, which involved heparin exposure. And we had another case from Arizona, Mayo, Arizona. And so it's a helpful tool, but we need more focused therapies. It's premature for me to speak now, but we have some ideas on how we could have targeted therapies. IVIG, you have to give just a boatload of that molecule. It's non-specific, but how do you specifically tailor this for this disease? Hopefully that'll be a future talk. And then sort of moving on to some of these new entities, because I want to tell that story because we're quite excited about this. This is called monoclonal gammopathy, or sometimes oligoclonal gammopathy of thrombotic significance. We have to give this a name. We call it MGTs, and already some people I know call it maggots because it's what it sounds like. But you know, nonetheless, maybe it'll get a new name someday. I don't know. But for now, it's MGTs or maggots. So I'll describe two different flavors of maggots. One is transient. So you have a gammopathy transiently, right? It's a new concept, sort of, right? Because you think of multiple myeloma, for example, you know, you have a gammopathy which persists and causes problems. MGUS, it persists and causes problems. So what is a transient gammopathy? And then, you know, chronic MGTs, which, you know, I'm just going to call it MGTs. So again, the VITT reactions you're all familiar with. This came out in April. This was the top is from Germany. It's bottom from Norway. A series of patients, they had this disease. It was crazy. The mortality was insane. You know, 50% of the German group and even higher in the Norwegian group. Many of these were women. Many of these are healthcare workers, and many of the healthcare workers are female. So they thought there's a female predominance, although we're not so sure now. And this was from the United States within a week after the first report. The first reports were AstraZeneca vaccine. This is the J&J vaccine. This is from a colleague in the University of Nebraska. So it became clear that there's something going on here. And the interesting thing they found was that these patients test positive in the HIT ELISA that I described. So it's got antibodies to platelet factor 4. So since sort of we started getting contacted by a lot of these doctors, certainly in the United States and some outside, saying, can you tell us what's going on? So our efforts were focused on understanding what are these antibodies, how are they different from classical HIT antibodies. So we came up with a plan fairly quickly. My lab had just sort of woken up from the post-COVID freeze. And so I know a lot of people, but, you know, we tried to do our best. It took us maybe a little longer than it would have on a good day. But this is what we did. So we took these heparin-cephalose beads, which looks like this cannonball with this black squiggle that's depicting heparin. We treated them with PF4, which are the pink circles, or not, and then incubated these beads with patient samples, right? So if someone's got an anti-PF4 antibody, it should bind this bead, but the one on the left, but not the right. And then we elute these antibodies to study by mass spec. We want to understand, are these antibodies any different from HIT, or are they the same? And maybe for the sake of time, I'm not going to go through this whole figure, but except showing you the bottom. Dr. Murray has, and his lab has a very high level of expertise using mass spectrometry to characterize HIT antibody or any kind of antibodies. And so using a strategy which is described up top, you end up with the results. Just this is a cartoon, this is a contrived figure. In this case, we can say that this sample has two different antibodies. So the two clones making antibodies on the left is a G lambda, and on the right is a G kappa. So we essentially wanted to study this in the patients that we, VITT patients that we saw. But firstly, before we study them in mass spec, we want to make sure we are actually isolating these antibodies effectively. So all these black bars are the eluates from the PF4 bead. These gray bars are eluates from the control bead that has no PF4. And the readout you're looking at is platelet activation. So if you have antibodies, PF4 antibodies coming off the beads, you should have high levels of platelet activation. So you'll notice each of the black bars, you know, induces a high level of platelet activation in the assay called the PEA that I described. And the gray bar is just sort of background level of activation. So we were convinced that, okay, we have developed the biochemical techniques. It wasn't straightforward, so it took us some time to isolate these antibodies. And then we worked with Dr. Murray's group to characterize them. So I'm just showing you some representative figures. We studied 5 VITT patients, and obviously you're seeing just 3 figures because 3 of the patients look very similar to the one on the left here. So we saw 3 monoclonal antibodies. So each peak is a monoclonal. So monoclonal here, this looks like a biclonal. This looks like a triclonal and also some smaller peaks. So compared to what, so dogma up to this point was in HIT, you have a polyclonal response. The anti-PF antibody is polyclonal, okay? So here we're seeing, wow, these antibodies actually restricted. So we started wondering, and it's something we haven't proven yet, we were wondering if perhaps in some diseases like this, you have one plasma cell clone that just is so effective at producing very high producer of antibodies, and it takes a longer time for it to sort of slow down. So this is a persistent disease, and it's a severe disease. We're wondering if maybe some of that is in this is what that's what this data is perhaps telling us. Now, this is just a contrasting figure showing how a HIT antibody looks. Now, this is an N of 1. We think that now, based on some new data, that maybe not all HIT antibodies are like this. It's a very polyclonal response, but nonetheless, in this paper, we showed this HIT sample with a polyclonal response. Now, really interestingly, on the right is a patient with spontaneous HIT. As I mentioned to you, occurs in the absence of heparin exposure, also a monoclonal antibody. Now, we've done 2 other patients, it's also monoclonal. So there's some similarities between VITT and spontaneous HIT in the level of sort of clonality, restricted clonality. The interesting thing is you'll see here, which I didn't mention in the last slide, they're all lambdas. So G lambda, G lambda, G lambda. It's an N of 5, but then we have an Australian group that published a paper in Blood a couple of months after us, confirming there's some kind of lambda restriction in VITT. So far, our spontaneous hits have been kappa. So there's differences, but also similarities between the 2 entities. So, again, we think these are transient prothrombotic. Clinically, they're transient prothrombotic syndromes. We think that the antibodies, this clonal antibody is also going to be there transiently. We're in the process of doing work on confirming that. We expect that working with Dr. Murray's group, that we'll have the results very shortly. Some of the stuff is already done, so we're excited about getting that data out on VITT and spontaneous HIT. But moving on to sort of one of the more recent topics, we asked the question, okay, can this cause chronic disease, right? So somebody who's getting thrombosis at multiple episodes, so over time, having recurrent presentations with thrombosis. This is a very interesting case, and it's very unfortunate, I think, in science and medicine that many journals have moved away from single case reports, because in my opinion, single case reports can teach you an amazing amount of stuff, okay? Both about rare disease and also diseases that may not be as rare, but you're not trained to recognize, okay? Fortunately, blood still accepts single case reports. The amount of work that went into working up, so this is a case report I mentioned, working up this patient was just, this was about a year's worth of work. The paper has, 2 figures with 6 subfigures and 8 supplemental figures. So there's a massive amount of data, but I'm going to just show you the highlights of what this person had and how we try to figure out what's going on. So this is a man in his 60s. He lives in a different state. He's been to multiple health systems trying to get a diagnosis for his recurrent thrombosis and periodic thrombocytopenia. So these black dots are nadir platelet counts. You can see sometimes it's less than 150 here in the most recent 4 years, and then prior to that it's been higher. It's been 200s and so on. Year 0 is when he came to Mayo, right? It's always fixed the year 0. So everything prior to 0 is other places we've been in. So, so we came here, you see these multiple thrombotic episodes, which are sort of not adequately explained. The interesting thing here was he complained of backache 4 years prior to presentation, and they thought, someone did an SPEP, so, something related to myeloma. And you can see a very low level of a monoclonal protein. It's an IgG kappa, and it was very low, 0.1 gram per deciliter. But over time, it has sort of increased. It was about 0.6 when he presented here at Mayo Clinic. The other interesting thing that I didn't mention, and I think I took it out because I thought I'll run over, is that along his course, they gave him some heparin for the clots. And he gave it a couple of times, and both times he had what he described as reactions. He had some kind of shivering, fevers, palpitations, and they thought that maybe he's having a reaction to the heparin. Could this be somehow HIT? Okay, and these had drops in platelet counts too, and he's been given heparin. So the physician caring for him, very smart guy at the University of Michigan, he does a HIT ELISA test, and the ELISA test is positive. He does an SRA, which is also strongly positive, and he does this multiple times over time, always consistently positive. So it's almost looking like some kind of a chronic persisting HIT. And so the hypothesis we made at that point was we confirmed all the testing when he came here and he was positive and ELISA and functional tests. The hypothesis we made was this monoclonal antibody that has increased in strength, that is an antibody to PF4, right? And if that's the case, well, it can explain the chronicity of his symptomatology and the chronicity of the results in the HIT diagnostic tests. And this is, again, making a very, very long story short, and I'm not showing all the data in the paper, but on the left is characterization of the M protein, the monoclonal protein from his serum. And on the right is characterization of isolated anti-PF4 antibodies. So this is using the bead treated with PF4 strategy that I showed you before. And what I'll have you focus on is, so this is the M/Z ratio of the monoclonal. So let's say the M/Z was 2126.04. The molecular weight was 23,375.5. You look at this here on the right, it's 23,375.7. So the difference in M/Z and molecular mass is so small. These are essentially identical. We also characterized, Dr. Murray also characterized the heavy chains and showed that they're identical in terms of glycosylation pattern, et cetera, et cetera. So we're convinced now that this person actually has a monoclonal antibody to PF4, and we believe the first one that's convincingly described with this disease. Now, the really interesting thing and the obvious thing is, if that's true, you would say that when this person has had low M spike or low monoclonal levels, his platelet count should be relatively normal. And as the levels go higher, platelet count should drop, which is what you see in this figure. So if you have a monoclonal antibody at concentrations which are high, which is on the right here, so it goes from 0 to 1.0, you see that most of the time, 83% of the time, his platelet counts are below 150. And when the monoclonal levels are low, 87% of the time, the platelet counts are normal. So, and I should emphasize, each of these open circles are blood draws where the monoclonal antibody and the platelet count was drawn at the same time. And maybe there are 2 dots within 48 hours. So these is really solid, rich data that help us kind of make this. So one would hypothesize that if his monoclonal antibody is less than 0.4, he typically is going to be fine. He's going to be not having disease. In other words, we don't need to wipe out his monoclonal antibody. He's going to have, it's going to be hard to do. You can't really wipe it out. And so can we have a disease management strategy where we get the amount of monoclonal antibody lower? And so we're provided some options to him on therapy, and he's had some limited therapy that got the levels a little bit lower, but not sufficiently low. So likely he'll have to undergo more therapy. And this thing came out last week, I think, in Discovery's Edge. But I just wanted to say, they said Mayo physicians recently identified an additional case of MGTs, and I thought if there's time, I'll show you a little bit. I have 4 minutes maybe, and then 10 for questions. So really quickly, I'll tell you this is a second case from a neighboring state. You see multiple thrombotic events, but and some of the thrombosis associated with thrombocytopenia, like here, radial artery thrombosis, platelet count 100, stroke, platelet count about 100,000. But very different in terms of serology. So if you look at PT, that means patient I is initial, F is follow-up, does not react in the HIT ELISA. We use 2 different targets in the ELISA, PVS and heparin, completely negative. This is a positive control. So if you said to detect MGTs, if the patient's got thrombosis, got an M spike, do a HIT ELISA, you'll miss this. So as we're trying to highlight here, but clearly very PF4 dependent platelet activation. So this is the patient sample. When you don't add PF4 to platelets, there's no activation. You add PF4, pretty decent activation. So he's still sort of having this, and we've drawn him like 5 times. Each time he's got the same type of antibody. I should mention both patients are on anticoagulants as well as anti-platelet meds to keep them from having breakthrough thrombotic disease. And again, I won't go through this, but except to tell you that the M protein in the serum is the same as the M protein in the eluate. And I don't have, unfortunately, the time to tell you how we isolated the M protein from the eluate because it was very complex given he doesn't bind heparin PF4. So I'll just maybe stop after these last 3 slides because we're coming up on 50 minutes. In summary, the data support the view that PF4 in complex with platelets without any added heparin is recognized by HIT antibodies and VITT antibodies, as well as MGTs antibodies. This antigen-antibody interaction can perpetuate disease even in the absence of heparin. And the PEA, the assay I described, is at least as accurate as the SRA for identification of patients with HIT. This is going to be increasingly important. What I didn't show you is that VITT antibodies are not detected by platelets treated with heparin. So the SRAs are going to be negative. You need to have PF4 treated platelets for that detection. And for that reason, test systems using PF4 treated platelets will likely become increasingly important for diagnostic tests. And unfortunately, I think HIT outcomes are still suboptimal. We need more targeted therapies that decrease thrombosis but do not increase the risk of bleeding. And in that context, IVIG may be helpful, but again, I think it's not targeted. So we need targeted, kind of a targeted form of IVIG, so to speak. MGTs, this field just opened up. You know, people ask me, what is the incidence of disease? And say, I don't know. But, you know, is it 1 in a million? I think unlikely because, you know, as one person, I've seen 2 patients. And the second one, I wasn't even looking. It was just accidental. I can tell you that story another day. But we're really interested in understanding this. We're just beginning to talking to experts in the myeloma space and other that I don't typically interact with in my world. And also, what is the optimal management strategy? What should we do? If they have a crisis, you maybe give IVIG and anticoagulants. But what do you do to eliminate the disease? You know, both the patients I have are older people, both of whom have some health issues that need surgical intervention. And the surgeons for both those patients are unwilling to undertake surgery unless they're off of anticoagulant, which they cannot be off of because of the risk of thrombosis. So we need to have some strategies to address this antibody and put them in sort of a relatively safe zone, so to speak, before they can have surgery. And so we're, you know, characterizing the monoclonal antibodies of the patients, as well as, you know, I'm not an immunologist, but I collaborate with some. So they're studying the cells that are making these antibodies.
Excellent. Thank you so much, Dr. Padmanabhan.
Thank you for participating. Please click the button below to complete the evaluation and obtain credit.